Good morning, good afternoon, good evening, wherever you are. It's wonderful to have you here. This is the session, Leveraging Digital Tools for Stronger Health Systems. I'd like to welcome you all to the session. My name is Rashad Masood, and I will be chairing this session. With us today are four amazing speakers, and I will introduce them one at a time as their presentations come up. I would like to ask you to hold off on your questions till the end, after which we will have, after all four presentations, we will have a question and answer discussion session. When you ask a question, please address it to a speaker. Please let us know who of the speakers you're addressing it to. To ask a question, please type it into the Q&A section of the portal. With that, if I may move to our first speaker. Our first speaker is Mr. Mohammed Asmal Hussain. And Mr. Hussain will be presenting on mobiles, midwives to secure healthcare access of the urban slum populations in Bangladesh. Mr. Hussain has over 20 years of integrated sexual and reproductive health experience. He is currently associated with UNFPA Bangladesh as the program analyst for urban health and leading the health equity team of the office. He has a diverse educational background, which includes public administration, public health, and health systems management. His background includes innovative project design, strategic planning, resource mobilization, and technical advisory roles in public health in Bangladesh. Mr. Hussain's presentation is pre-recorded, and we will be listening to the recording now.
Hello colleagues, I welcome you to my presentation on mobile midwives to secure healthcare access of the urban slum populations in Bangladesh, which is popularly known as mobile midwives. So I am co-authoring this project with two of my colleagues. One is Dr. Dewan Mohammad Emdadul Haq, who is working for UNFPA, that is United Nations Population Fund, and Dr. Khalid Hassan, who is working for Digital Healthcare Solutions, which was previously known as Telenor Health. So let me tell you a brief background of this project. You know, in Bangladesh, at this moment, 37% populations are living in urban areas, and of them, 25% are in slum, meaning that 60 million populations are living in Bangladesh at this moment in the slums. And those who are living in the slums, they are having only 13%, having access to public health facilities. And in general, people are having difficulties finding quality doctors. This is because only 5 doctors are allocated against 10,000 populations in Bangladesh. This is leading to a high out-of-pocket expenditure, which is 67%, one of the highest in the globe. And for that reason, every year, 3 million people sent to poverty by health expenses every year. So in that background, in that context, UNFPA, having its midwifery experiences and digital healthcare solutions with the telehealth experiences, joins together to implement this project. So the objective of this project is to increase the rate of facility-based deliveries, as well as to increase the consideration and uptake of long-acting family planning methods in Bangladesh. We targeted to reach 10,000 pregnant women for the slum women located in Mohammadpur, Dhaka, Bangladesh. So the way basically we are working, you know that Telenor Health, they are recruiting and assigning cohort from the Mohammadpur Fertility Services Center, and from there, they are providing 4 different kind of services. One is consultation, second is navigation, third is content, and 4 is voucher. So they are also providing kind of midwife navigation, meaning that once any women are referred to facilities, there is a point person who is also a midwife to accept that women for the further kind of treatment, other kind of services. So what are the services basically you're talking about? So when we tell consultation, it basically means both free phone-based inbound and outbound call. Anytime, any midwife, any pregnant woman who was registered can call to a number 24/7 to address pregnant women's need. Further, if any women need any kind of further consultation with the doctor, they can definitely reach out to the doctor as well. Referral meaning that this midwifery center, they are helping participants to refer to health facilities as and when needed. And with that services, we are distributing, engaging in high quality health information to participants via SMS messages. At the end, two of the cohorts population, they are receiving 1,000 Bangladeshi taka as a virtual vouchers so that they are financially accessible to the delivery services and they are able to bear other associated costs. So as I mentioned, there are basically three cohorts of the populations. So one cohort A, so we are having this blue color scratch card. For cohort B, we are having this green color scratch card, and cohort C, we have this yellow color scratch card. So what is happening? So whenever any pregnant woman who is choosing this color randomly, so they are eligible for having these 4 different services under cohort A. Those are midwife teleservice, facility referral for support, and health tips and cash claim. And those are having this green card, green stress card. So they are having 3 services except that cash claim. And the cohort C, they are only having this yellow card. So that is how we are trying to see which one works best, so that after the piloting of this intervention, we can take it up, we can scale up any one of this intervention. So you can see we are distributing these 3 different colors leaflet to the women, and they are choosing themselves, randomly, and they are being eligible for having either cohort A, cohort B, or cohort C kind of services. So what the midwife teleservices include? So as I mentioned, they are having 24/7 free inbound and outbound call. So they're eligible for any kind of advice by the midwives. If necessary, they can also be referred to the doctor. Also, if necessary, they can also be referred to the facility. So how that consultation journey works? So any pregnant woman, they can call to this number 08000016 Once they dial this number, they can talk to the doctor, or they can also consult with the midwife. Then you can see the referral facility center journey. So how they are basically received in different services. So once midwife navigate customer to Mamatur Fertility Services and Training Center, so they can be able to visit nearest doctor for any antenatal care. They can also visit hospital for delivery, and also they can visit nearest doctor for postnatal care. So how they are claiming cash? So as I mentioned that cohort A and C, they will be eligible to receive this 10,000 taka. So it is only eligible once a pregnant woman go to hospital for delivery. When the delivery is done by the doctor or midwife, so Mamatur Fertility Service and Training Center, they verify the document, they send that information to Telenor Health or this digital healthcare solution. Then Telenor Health disburse this claim through bKash, a kind of mobile kind of wallet kind of services or rocket in Bangladesh, and that is how we are trying to see this cohort A, B, or C, which one works best. Thank you.
Thank you very much, Mr. Asmal Hussain. Wonderful presentation. Mr. Hussain will be with us at the end to answer any questions that you may have. In the meantime, I would like to move to our next presentation. Our next presentation comes from Dr. Mohammed Shafi. Dr. Shafi is a DRPH, Doctor of Public Health Scholar at Boston University School of Public Health. His presentation is on countering vaccine hesitancy, development of a new mobile application Pradiro, the AVAX app. Dr. Shafi is a physician, public health management specialist with a decade of global health management, academic and research experience in Asia, Middle East, Africa, and the US. His key areas of interest include health systems research, social determinants of health, minority health, and migration. And he is currently a scholar pursuing a doctoral degree at BU. His presentation is pre-recorded. We will listen to the pre-recording. We do not have Dr. Shafi with us on the line, at least we do not see him with us on the line as a presenter. So we may not be able to take questions for Dr. Shafi, but let's see, he might join us a little bit later. With that, let's listen to the presentation itself.
Hi all, so this is Dr. Shafi. I will be talking to you on one of our projects that we did in India under the decision maker-led implementation research project supported by WHO Alliance. So this is on the development of a mobile application that we undertook as a byproduct of our project that was on vaccine hesitancy. So our team is primarily from Global Institute of Public Health in Trivandrum, Kerala, India. Our primary principal investigator was Dr. Anup Nair, who is a primary health center medical officer with the government of Kerala. So our objective was to develop an evidence-based mobile application so that we share information related to childhood vaccines, especially thus concerning some of the misconceptions among the general public. So as I said earlier, we used the data that we generated from a Delir project, which was supported by the WHO Alliance for Health Policy and Systems Research. And then we used the information that we gathered from this research projects to develop the mobile application. It was primarily using in-depth interviews and focus group discussions with a variety of respondents, including physicians, school teachers, religious leaders, and communication experts. As a background, I would say that the project was undertaken to understand the dynamics in which the resistance or hesitancy to vaccine and vaccine programs occurs in the community, especially in the context of social media, increasing influence of social media. So basically, we had interviews and focus group discussions with a variety of actors, right from medical professionals to laymen, also including some of those people who are in the anti-vaccine movement. So once we gathered the information, adequate information, what we did was like we enlisted all the concerns, the doubts and misconceptions that we could gather from the various data sources that we have. So in addition to the in-depth interviews and focus group discussions, we also looked into some of the YouTube and WhatsApp communications which had anti-vaccine informations and messages and videos. So what we did is our research team then grouped them together and organized them into sub-themes and themes. And then we had a team of pediatricians, public health and social scientists who looked into each of those concerns. And then we developed appropriate scientific evidence-based clarifications for those concerns in simple language. First it was developed in English, and then it was translated to Malayalam, the local language. And then we back translated, and then we finally approved it after having checking the face validity with a group of laymen. So finally, we had a group of software developers who developed the mobile application for us, which looks like something like this. So basically, this is available both in English and Malayalam in the Google Play Store. It has different components. One is about the vaccine schedules, that the commonly used vaccines in our national program, and the additional vaccines that are recommended by various professional organizations. Then there is a separate section on myths and facts, and then FAQs, and also to connect with us for laymen or health workers if they need more information. So it used very simple techniques or methodologies for anyone to access it by typing using the local language or English. a few keywords which will generate the appropriate search results for them. So specifically, we had the myths and facts ordered based on our research findings, but also we kept it open for many other things using the information in the backend, so that they can use the vaccine schedules. They can find out when a vaccine, what vaccines are due for them, if they know, if they enter the date of birth of the child, and things like that. So we have, as I said, we have an FAQ screen based on all the different misconceptions that we came across in the research process. So we have specifically answered all those questions and try to clarify and clear the misconceptions that have come up in the research process. And also we had, as I said, we have an opportunity, we have created an opportunity for healthcare workers as well as the common man to interact with us by using their registered mobile number. So to conclude, this mobile application will be helpful for healthcare workers and public in understanding some of the key misconceptions and to clarify misconceptions in vaccine and vaccine programs. We now plan to undertake a field testing of this application among healthcare workers and general public. Thank you for listening.
Thank you. I want to, first of all, thank Dr. Mohammed Shafi for the pre-recorded presentation. I also want to, before I proceed to the next presentation, acknowledge that we already have a question that has come in for Mr. Asmal Hussain. And I want to make sure that I say that as soon as the 4 presentations are done, we will start with the questions, and that will be the first question I will ask Dr. Hussain, Mr. Hussain, to address. In the meantime, of course, if you have any questions, please feel free to put them in, and we'll take them in the order that they come in. With that, if I may proceed to our next presentation. Our next presentation comes from Dr. Saowei Wang, who is a lecturer at Lanzhou University. Her presentation is on smartphone-based virtual patients to improve competency of primary healthcare workers in rural China, a cluster randomized controlled trial study. Dr. Saowei Wang is a senior lecturer with 18 years of teaching and research experience working in the School of Public Health at Lanzhou University. She received her doctoral degree in public health at the Chinese University of Hong Kong. Her research focuses on health systems research, evidence-based health policy and management, particularly on quality of care assessment and improvement. She's participating in a large study on the quality of primary care in 7 provinces of China, using unannounced standardized patients, and also acting as the principal investigator for smartphone-based virtual patient training to improve competencies of primary care workers in rural China. Dr. Wang, please, Dr. Wang will be presenting live. All yours, Dr. Wang. Thank you.
Thank you, Masood. I will share my screen. Okay, I think it's working now. Okay, good morning, or good afternoon or evening. My name is Xiaohui Wang from School of Public Health, Lanzhou University. Lanzhou is located in northwest China. If you can imagine a map of China, it's the geographic center of China. First of all, I would like to express my big thanks to this symposium organizer and the chair of this session. It's my honor to present an ongoing project titled Smartphone-Based Virtual Patient to improve competency of primary healthcare workers in rural China, a class randomized controlled trial study. I will go through the details by introducing the background of our project, the objectives, and the methods. A group of researchers in China got together back in 2017, and we decided to create this network named Primary Healthcare Quality Cohort in China, ACACIA in short, and use standardized patient to assess quality of care and do research based on its data. The background of this is many of us in China felt because of traditional heavy data protection ideas, there's little data sharing among the researchers. even though the government is collecting a lot of data, but the challenge is still so big. So we think what is the most important data for research and also for the health reform of China? We decided that the quality data is most critical. And we think we will do this project together as volunteers at the very beginning, even without any initial financial support. A member of the networks come from more than 20 universities. We get together by Professor Xu Dong. We contributed our financial, human, and also relational resources to make this project happen. And we also agreed that once the data is connected, those data will be openly shared initially within our group, then later to the broader public. Unannounced standardized patient and virtual patient method will be employed to assess and improve quality of primary care. Under the Acacia network, 12 most commonly and frequently seen conditions in primary healthcare settings in China have been developed based on clinical practice guidelines or evidence-based standard process of care and treatment plans. Okay, WIPI is an interactive computer-based simulations designed to use complement clinic or medical training, education, or for assessment goal. As mentioned, we have developed 12 WIPI cases which create high fidelity and interactive simulations of doctor-patient encounters, which can be easily implemented using smartphone. Smartphone-based virtual patient is an alternative and improvement of SP to assess and improve PHC workers' competency. Each case includes 5 domains, namely history taken, physical and lab test, diagnosis, treatment, and also the health education part. The SVPT project was sponsored by China Medical Board. The researcher comes from the Acacia network and all the institutions listed here. The objective was to implement SVPT as a new training approach among primary healthcare workers in rural Gansu, where I based, and then to evaluate the impact of this innovative training approach on competency improvement among primary healthcare workers. The direct beneficiaries of this project are the physicians take part in SVPT program. And the ultimately goal of this project is to improve quality of care, thus improve health outcome of the rural residents. Class randomized control trial research design will be conducted to test the hypothesis of interest with SVPT arm as intervention group and a traditional training arm as a control group, where randomization is at the THC level and the intervention will be conducted at the individual physicians level. And over 500 physicians working in township health centers in Huilin County will be randomly assigned to intervention group or control group. To eliminate contamination, all eligible physicians intervention THCs are expected to participate in SVPT, while those in control group will continue current employed traditional training approach. This flowchart shows the enrollment, allocation, intervention, and the follow-up procedure of the study. The local health bureau will facilitate SVPT process to be specified. They promised to embed SVPT in their routine job and issue documents to facilitate THC mobilization and participants recruitment. After randomization, we will visit the THCs in intervention group in the field. The training process, as shown here, will include 4 major steps. In step 1, student helpers will guide the participants to download the app and register their own account. Then the participant will need to log on the system and take the VP system test. The score will be collected before the training of VP cases. Followed by this, we will conduct the training. Consider the routine workload of the physicians. We propose to use 1 case or one condition each month for the training. Altogether, it will take about 12 months to conduct the training. The physicians can practice the simulations at any time in a given time slot. The first part is to conduct a follow-up test at the end of each month and collect the score again. The primary outcome is competency of the participants, and the secondary outcome variables are quality of care indicators, which will be collected used as fees to assess the real clinical practice of the physicians. There are also other variables we will collect and analysis, such as facilitated information, qualification of PhD workers, and the number of visits, etc. Data analysis will be conducted on both cluster level and the individual level. We will use REAIM evaluation framework to guide to evaluate to investigate the impact of SVPT training method. Due to the pandemic, we failed to implement the training last year, but it will happen soon this year. Hope I can share our programs and the experience and the lessons learned in the near future. That's all for my presentation on behalf of Acacia working group. Thank you.
Thank you very much, Dr. Wang. Wonderful
You.
presentation. With that, I would like to move to our fourth and last presentation by Mr. Gerald Mwapasa, the Country Project Coordinator for Serge Africa College of Medicine. The presentation is on a WhatsApp group forum for improving rural population access to specialist surgical care in Malawi, a prospective observational study. Gerald Mwapasa is a Malawian researcher with experience in medical research coordination and clinical trial monitoring. He holds a master's degree in clinical trials from the London School of Hygiene and Tropical Medicine and a Bachelor of Science from the University of Malawi. Mr. Mwapasa, please, all yours.
Thank you very much. The presentation, the introductions have been done already. But for my presentation to make sense, I think I need to introduce our situation first. Malawi is a poor resource country in terms of personnel to do surgery, the infrastructure to deliver surgery, the equipment, and even the supplies. And the problem is mainly waste in the rural areas because the 80% of our population is rural based. And this rural population is scattered by what we call district hospitals, and in those district hospitals, there's no specialists resident there. We have non-physician clinicians called clinical officers who deliver the surgical care in these districts. And for the few number of specialists that we have, all of them are based in rural, in urban central hospitals, which act as a referral hospital for all these district hospitals that we have. And this Serge Africa project's aim was to scale up surgery to this rural population. And what we did was to come up with just a moment. I'm having a bit of a hiccup. My presentation has hung a bit. I don't know why the slide can't move. Can you see my screen?
Yes, we can. Try to move your slide,
Okay.
please.
Good. Now we can move. So I've introduced about our situation in Malawi. 80% of our population is rural, and the rest of the specialists are in the urban central hospitals. So to support these DC hospitals, we created a forum where we had all the specialists in the group, all the anesthetists, and all the clinical officers in these rural DC hospitals, so that when the DC hospitals are presented with a surgical case, before they decide to refer to the DC hospital, to a central hospital, they will post the case on the forum for specialist advice. So these clinical officers and who provide surgical and obstetric care for every patient that they feel should be referred to a central hospital, they will post it on the forum, and the specialists on the other end will respond on how best they can manage that particular case. So just to give you a feel on how things have gone, I'll play a video by our specialists as well as the clinical officers on their experience in this project.
We tried to come up with a way of connecting the DC hospitals with the consultants at Queen Elizabeth Central Hospital. So WhatsApp group was the idea that we came up with.
I think it's being very effective at that because it's kind of instant consultations. People with questions are getting feedback from a specialist almost immediately.
We post even the pictures, and the consultants do see the pictures, and they can advise to say, well, proceed to this side so that you are able to reach the problem.
You give feedback immediately, you say, deal with it there, do this, do that, or, do these investigations and call us, or send the patient up, or sometimes don't send the patient up.
We find it very useful because we notify them in advance so that they should get prepared.
You need to discuss the cases even before you refer them. They say, oh, well, Mr. Malunga, before you refer the patient, do A, B, C, D, E, because this patient has to arrive in Queens once in a safe condition.
It's pretty helpful in terms of giving them advice. For example, if it's something that they can do at the district hospital, at least you'll be able to give them advice on what they need to do for the patient before they refer, or at least as they refer.
When we send the patients, we get even feedback right away on the WhatsApp forum.
I love the feedback and even in the teaching itself, because medicine is dynamic. Each and every day you need to learn.
We have got 10 DC hospitals, and in terms of membership, individuals, we have got 100 individuals, almost 100 individuals in the group. They have access to about 14 consultants. The good thing about the WhatsApp group is that once they post a case on the group, 1, 2 or more consultants will contribute on the case, which creates that access to many consultants at once.
We're not reaching only to one person, so you reach out to quite a number of clinicians. So as much as I may advise one person to prepare a patient in a certain way on a specific patient, I'm sure somebody else is also learning from the same group.
The best thing is that not only that we are given feedback, but also we are learning.
There was quite a big gap between us and them. But now the WhatsApp group, basically, we've come like a family. We can interact, we can communicate, and they're not afraid to ask for medical opinions, surgical opinions.
It's a no-cost thing. It just takes people's time. There's no money invested in it, so there's no reason for it not to continue.
Through Sage Africa, these are happening, and that's what Minister of Health is supposed to do anyway, and the Central Hospital is supposed to do, and Sage Africa is just helping, coming in the right direction at the right time.
And just to give you a bit of results from the data that we have analyzed, we have noted that for the advice that the specialists gave the DC hospitals, about 60% of them, of those referrals that they consulted, they were advised to refer right away. But we also see that about 1/3 of the referrals, they were told either not to refer or to refer but later. This means that the case should have been handled at a DC hospital, or even if the patient was referred, couldn't have benefited from specialist care. So this referral system that we try to implement using the WhatsApp group has really improved on the sending of appropriate referrals to central hospitals, and also presents an opportunity for cost saving for hospitals, because every avoided referral is a saving to a DC hospital. And also this access to timely and affordable surgical care for the limited number of specialists that we have resident in the urban area is really feasible with the WhatsApp group forum. And also, as you saw in the video, the mentorship that is happening through the WhatsApp group, through the physicians, the specialists, explaining why a case should be referred or not, is really helping our referral system, especially on these surgical cases. Thank you.
Wonderful. Thank you very much, Gerald Mapasa. Wonderful presentation. If I now may turn to our question and answer discussion session. We have a question from Mary Hadley, and the question, I believe, is directed to Mr. Hussain, but Mr. Hussain has dropped off the call. Can I check if in any way Mr. Hussain is able to address that question? I do not see him on the panelist list. Maybe IT, could you help me check if he's at all on the call? He's not. Okay. So, Ms. Hadley, I apologize that he's not with us to be able to address this question. Let me ask if there are other questions, comments on the presentations. Any of the presenters, we have two of our presenters with us, Dr. Wang and Mr. Mapasa. Would you like to add anything to what you have said?
Okay, I can come first. The reason people will be asking, why did we choose WhatsApp out of everything? The reason why we chose WhatsApp was because it's widely used by the specialists at the central hospitals and the DC hospitals. So if you go anywhere now, the network, even though we are in a rural, we are in a poor resource country, but phone network is everywhere, and it's easy for the DC hospitals to communicate to the central hospital. And the easiest way, most of Malawians communicate through WhatsApp. And the other thing is that for us to add members in the group, they had to go through a form to ensure that whatever they post there is confidential, faces are covered, there are no names posted, just to ensure that the information that is posted there has enough confidentiality that is required. Thank you.
Thank you. Dr. Wang, is there anything you would like to add to what you have said earlier on your presentation?
Oh, thank you. Actually, the project I introduced just now is a project use a smartphone-based virtual patient to train rural healthcare workers. Actually, we are actually doing SP. We are using the SP to measure the quality of care, especially the process of the care. And we will compare the process of the care, and also we will evaluate the competency of the primary healthcare workers, and then found out where are the weakness and how can we improve it. So I think it's a very important project here, and also I think maybe in the near future we can introduce this method or this app to other countries. I think it's worth doing. Yeah, thank you.
Thank you. Let me turn to our participants in the session. Any questions from your side? And if not, maybe I can ask the presenters to switch your videos on, and maybe we can have a general conversation. Thank you. So one of the things that's going through my mind, let's step out of the 4 presentations we just heard. This session is about leveraging digital tools for stronger health systems. And the pandemic has really taught us a lot about leveraging digital tools. Not that we didn't know a lot before the pandemic, but it certainly created the environment in which we've had to leverage the electronic tools much more in health systems. And I don't know, your work is very specifically, your presentations were very specific, but if we can step out of the presentations and just sort of think about the implications of the research that you're both doing overall on going forward, what would the post-pandemic world look like, given what you know about digital health? Please, Dr. Wang or Mr. Mopasa, would you like to start?
Yes, I'll start. Sage Africa project had 2 components. Apart from the WhatsApp group forum support, we had visits by the specialist teams from Central Hospital, comprised of a surgeon, obstetrician, a theater nurse, and an anesthetist, going down to the district hospital to mentor them in how to do surgery. And these visits were happening once every 2 months. Now, with COVID-19 coming in, those visits stopped right away because of the travel restrictions, etc., etc. But the beauty about this WhatsApp group forum is that it continued. Yeah, the referrals were still happening, and the consultations were still happening. The mentorship was still continuing even up to now. We stopped our visits. The visits are not happening, but the forum that we created through the Sage Africa project is still there, and projects have got a timeline. Yeah, we are ending the project in the next 3 months, but we see that this forum will continue because we will hand it over to the users, and they'll continue using it with or without COVID-19 there, because the referrals will continue happening. So that's the comment that I would like to make.
That's terrific. Thank you. Dr. Wang, what about your thoughts on this?
As just mentioned, actually the pandemic forced us to close down lots of things. And I tend to say the situation is under control here in China now. But during the pandemic, I think it also forced I can say that it's another way to see a doctor or to seek the health services. And also in China, lots of e-health service appeared. And we are going to evaluate the quality of the e-health service due to the pandemic, and the people cannot go out, and the people tend not to go to the hospital as a first choice. And I think it's a big concern, the quality of the e-health service. I think it's also very important, and maybe the electronic tools or the apps we are now try to develop or try to use will help the especially help the rural community health workers to improve their competency and to improve the quality of care and also improve the health of the rural residents. Thank you.
That's great. Since we don't have any questions coming in, I'd like to use our time just to think about leveraging digital technology. And I can see a lot of uses, and I can see that, how we've really transformed the way that we operate, and digital health, including, the Zoom that we're using right now, has really transformed the way we operate. But I'm aware that we have, for example, one of the numbers that keeps coming to my mind in the US is that 1/3 of the raw mortality, that is the excess mortality, that is number of deaths in 2020 compared to 2019, 1/3 of those deaths were not COVID related. They were really more related to discontinuity of service. Now, when I think of a number like that, I think, well, that's a huge issue. And although we did pivot to telehealth very quickly, but somewhere something wasn't right. And I would like to, as researchers in this arena, I would like to get your thoughts on what is some of the, we know post-pandemic, we are going to continue using telehealth. It's, it's proven its value, but how can we also be cautious about any negative effects that the overuse or the inappropriate use of telehealth could get us? I don't know if you've thought about that, or if you have any ideas about what are the things we should be careful of and how can we prevent that? Any ideas?
Yeah, for us, one of the things that we tried to do was not to replace the normal referral system with the WhatsApp group forum. So the normal referral system in Malawi, that the patient will carry a form and take it to the central hospital. Once they are treated, the assumption is that they will go back to the DC hospital with a feedback on how they have been treated. Another way would be normal phone call. A clinician calling a specialist in the central hospital to ask for ideas. And we never stopped that. We said, because one of the minor disadvantages with the WhatsApp group forum is that someone will post a case on the forum, but it will take a specialist to see the message and respond. While a phone call, if someone calls, they will answer right away. So what we said is, if you don't get a response right away, call the specialist. And these interactions that are already there, that have been built through the WhatsApp group forum, improve the relationship between the specialist and the DC hospital team. Previously, there was a big gap because these people we are not talking at all. They had no forum to meet. And you can see the effect of putting people together. Yeah, so people are confident to pick up a phone and call a specific specialist that can help them. Even if they don't get a response on the WhatsApp group forum, we know there's a lot of communication happening in the hindsight, which we like a lot. We encourage them that if you talk to a specialist, don't stop there, post it later so that others can learn as well that what you have been advised on the phone. Thank you.
That's great. Thank you. Dr. Wang, your thoughts?
Yeah, one point I think of is that if we use the digital technologies, and also maybe I think the doctors or the physicians will rely more and more on the technology. And I think maybe one negative impact of this thing is to minus the patient-physician communication. I think I saw a paper, I think maybe 1 month ago or recently. It's about the use of masks, and the mask will bring difficulty to the physician and patient communication. And I think if the physicians relies more and more on digital technologies, things will also happen, I think. Yeah.
Thank you. We do have a question from Tala Fahouri. The question is, what type of mobile applications would most would be most useful to facilitate a better physician-patient interaction in the COVID-19 pandemic? And I guess this must be to both of you. Who would like to go first? Dr. Wang, would you like to start?
Yeah, thank you. Thank you for this question. I think as for the type of mobile application, most useful to facilitate a better physician-patient interaction in a pandemic. I think maybe if the person cannot go to the hospital, we now have the ehealth system, as I mentioned, and the patient can do some consultation, pre-consultation from the apps, and to ask the conditions and post their concerns about the conditions. And then if the condition is very necessary for you to go to the hospital, then the physician will recommend you to go to the hospital or to the tertiary hospital. But if it's just a minor question or problems, it can be solved, and you don't have to go to the clinic. Yeah.
Great. Mr. Mapasa?
Yeah, one of the things that COVID-19 has done to us is limiting travel from one area to another. And in our case, as I said, 80% of our population is rural. And there's inflow of referrals from different hospitals to the central hospital. What the app that would work is that can allow the specialist advise the lesser qualified clinician to do a procedure from where he is. So if a case is referred at a district hospital, if a case can be managed there should be a specialist sitting 400 kilometers away, interacting with the lesser qualified clinician in the rural hospital and advise them how best they can handle a case. Of course, what I'm advocating is that they should try what they cannot afford, but cases that can be handled at a rural district hospital should be handled there with the existence of a supervisor wherever he is. So in our case, we have had such cases where you have got a case at a district hospital, but the specialist has said, don't refer. There's no need to travel. I'm there monitoring, tell me what's happening, and they operate together virtually. And once the operation is done, the specialist is also able to monitor how the patient is doing. And most of them have done well. So we only want appropriate travel, appropriate referral from the district hospitals to the central hospital. So I wouldn't mention the specific app that would work, but for us, the WhatsApp group, the WhatsApp is working perfectly. With our setting, yes, we know there's a little bundle that is used on WhatsApp, but we literally spent nothing. As long as you have put WhatsApp, these things were happening. Thank you.
Wonderful. Well, I want to thank you both very much for answering this question, and Ms. Fahouri for asking the question. I'd like to, we have IT with us. Maybe IT, I can ask you to record the question from Mary Hadley, and I guess you do have the email addresses for both for participants and presenters. So maybe the question from Mary Hadley could be sent directly to Mr. Hussain so that he can respond, if that's something you can do. Hans, can you confirm if this is a possibility?
That's fine.
Thank you very much for doing that. And I apologize, Ms. Hadley, that this is, Mr. Hussain dropped off. Are there other questions, comments, any other thoughts going through anybody's mind? If not, I would like to thank you all very much. I'd like to thank our 4 speakers for wonderful presentations. I'd like to thank our participants for being with us and for the great questions you've asked, and the conference organizers for organizing this session. Thank you all very much, and I guess we can give back a few more minutes to everybody today. Thank you all. This session is now adjourned.
Thank you.
Bye-bye.